Hi everyone, welcome to Quick Care Bites. Today we will be discussing the management of status asthmaticus, its pathophysiology, and specific pointers on ventilatory strategies and rescue maneuvers. My name is Claire, and I'm a respiratory medicine specialist and intensivist within the National University Health System. Status asthmaticus is a severe asthma exacerbation characterized by markedly increased airway resistance. Bronchospasm and mucosal edema causes airway narrowing, which then leads to an increase in airways resistance. And what happens is then a diminished expiratory flow and incomplete emptying of alveolar gas. Dynamic hyperinflation occurs when reduction in expiratory flow leads to incomplete exhalation of the delivered tidal volume. As seen in this diagram over here, each subsequent breath actually leads to an increase in end-expiratory lung volume. Air that is left behind at the end of exhalation exerts a positive pressure in the lungs, known as auto or intrinsic PEEP. The deleterious effects of intrinsic PEEP or auto PEEP are that of hypotension and barotrauma. During inspiration, with successive increases in intrinsic PEEP, intrathoracic pressure increases, and this is transmitted to the right atrium. Right atrial pressure increases, leading to a fall in venous return and a fall in cardiac output. Excessive PEEP also increases RV afterload by increasing pulmonary vascular resistance and overall leads to hypotension. On top of this, excessive PEEP can lead to barotrauma and complications such as pneumothorax and pneumomediastinum can occur. When first referred a patient for ICU review of a status asthmaticus, we first needed to determine the severity of the asthma exacerbation. And this was taken from the BTS 2016 asthma guidelines. A severe asthma exacerbation would be one where the patient is tachypnic, they have a respiratory rate of more than 25 breaths per minute, they are tachycardic, and they are unable to speak in full sentences. A life-threatening asthma exacerbation would be one where patients are hypoxemic, they have poor respiratory effort, they may have rapid shallow breathing, appear exhausted, have altered mental status, hypotension, arrhythmias, or a silent chest. It's important to note that a normal capnia on an arterial blood gas is a sign of impending respiratory failure, as most patients in an asthma exacerbation would hyperventilate. Normal capnia would therefore suggest a respiratory muscle fatigue and a decrease in minute ventilation, which may then signify the patient tiring out. A near-fatal asthma exacerbation would be one with hypercapnic respiratory failure, or one in which mechanical ventilation is required. Initial management of a patient with a severe asthma exacerbation would be to stabilize the patient's airway, breathing, and circulation. If at the initial time there is drowsiness, confusion, or a silent chest, oxygen supplementation should be started and preparations for intubation should be made. If it is a severe asthma exacerbation but the patient does not require imminent intubation, then treatment would involve that of supplemental oxygen, performing nebulizations back-to-back every 15 minutes, to start the patient on IV hydrocortisone 200 mg once, followed by 100 mg Q8 hourly, and a bolus of IV magnesium sulfate 2 grams. If there are any signs of a concomitant pneumonia, empiric antibiotics can be started. And what is crucial in a patient with a severe asthma exacerbation is really frequent reassessment of the patient's response. So the next question in a patient who has severe asthma exacerbation is whether or not there is a role for NIV. I think ultimately the use of NIV in asthma is still controversial. There is only one major randomized control trial looking at severe asthma, and it is by Sorosky and published in Chest in 2003. Overall, the numbers were small, with a total of 30 patients, half being randomized to BiPAP and half to conventional therapy. And he found that a BiPAP was actually shown to improve lung function tests and reduce hospitalization. But the question really is, are these patients really patients with status asthmaticus, severe asthma exacerbation, if the patient can be discharged home? And therefore, if initiating a patient on BiPAP, I think first of all, we really need to answer the question, does this patient need to be intubated instead? And secondly, if BiPAP is being employed, it should be initiated in the ICU or the high dependency setting with close monitoring. Indications for intubation in a patient with asthma exacerbation can be based on clinical parameters or based on the patient's arterial blood gas. Clinically, if the patient is in cardiac arrest or there is a respiratory arrest or profound bradypnea, silent chest, The patient appears exhausted, they have altered mental status, such as lethargy or agitation that actually interferes with oxygen delivery or treatment. These are all indications for intubation. Looking at arterial blood gas, a pH of less than 7.2, successive increases in arterial PCO2 or a PCO2 of more than 55 to 70, or a low PaO2 of less than 60 despite the supplemental oxygen would all be indications for intubation. I think overall clinical judgment takes more importance over numbers. So if the patient is obviously in respiratory distress, they have a respiratory rate of more than 40, you are worried about complications such as barotrauma, or there's unresolving lactic acidosis, then the patient should be intubated. So how then would we actually intubate a patient with a severe asthma exacerbation? I think in general, most physicians would opt for rapid sequence intubation, though some case reports or case series do describe the use of awake fiber optic intubation. But in practice, most of these patients are in significant respiratory distress and therefore would not be able to cooperate with awake intubation. In selecting endotracheal tube size, a large size ETT should be chosen, usually at least that of a size 8. And this is to minimize any additional airway resistance that is posed by the tube. And a larger ETT would also facilitate suctioning for secretion removal, as well as bronchoscopy if required, as mucus plugging is fairly common in a patient with severe asthma exacerbation. Consider the use of pre-medication, such as IV fentanyl, 2 to 3 mites per kg to attenuate laryngospasm. And often used induction agents would include that of IV ketamine or IV propofol for their bronchodilatory effects. In terms of paralysis, rocuronium can be used, and this would actually avoid any concern regarding histamine release from neuromuscular blockade. Succinylcholine theoretically can cause histamine release, but it has been safely used in practice. Post-intubation, it is important to remember not to be over-enthusiastic about bagging, so controlled hypoventilation should be adopted. Avoid being over-enthusiastic, squeezing too hard and too fast in the heat of the moment, as this may actually worsen dynamic hyperinflation. A common complication that can occur post-intubation is that of post-intubation hypotension. And commonly in patients with a severe asthma exacerbation, this is a result of dynamic hyperinflation due to the high intrathoracic pressures leading to reduced cardiac filling, or due to a tension pneumothorax developing. So clinical assessment for these two most common causes should be performed. Otherwise, consider other causes of hypotension as per the causes of shock. Consider the effects of your RSI drugs, as well as possible concurrent sepsis, hypovolemia, or a new cardiac event. In general, management of post-intubation hypotension would include that of fluid resuscitation, ensuring the patients are volume replete to avoid the deleterious effects of dynamic hyperinflation on cardiac filling. Perform a clinical examination looking for evidence of pneumothorax. Check the patient for auto-PEEP. Start vasopressors if required, so phenylephrine boluses in the moment, and then subsequently a noradrenaline infusion. Consider the use of a point-of-care ultrasound, chest radiograph, and ECG to elucidate the cause of hypotension. And if the patient is hypotensive due to dynamic hyperinflation, consider decreasing the PEEP or the rate of ventilation. And in severe cases, consider disconnection of the circuit. So how do we suspect that the patient is developing auto-PEEP? So 3 main ways. So the first is that of the failure of the expiratory flow waveform on the flow time curve to return to baseline. So if you look at the photo here and the pink arrows, the normal inspiratory flow waveform is the green waveform, and the expiratory waveform is that of the yellow waveform. So you see that the expiratory flow waveform actually fails to return to 0, and this is a sign that there is auto-PEEP going on. Another way to determine auto-PEEP is actually to perform expiratory pause maneuver. So the machine is paused at end expiration, and intrinsic PEEP can then be measured. A last sign of increasing auto-PEEP would be that of increasing plateau pressure. So as dynamic hyperinflation occurs, lung compliance decreases due to overdistension, and this is reflected by an increase in the plateau pressure. So this is a diagram that actually demonstrates what you'll see on the ventilator as the expiratory pause maneuver is being performed. So you have a patient who breathes in, so pressure increases during inspiration, and then inspiration stops and pressure decreases. And as pressure decreases, the expiratory pause is performed. And you can see that the total PEEP would be from this black line to the dotted line at the top. And therefore, the intrinsic PEEP would be equal to the total PEEP minus that of the machine PEEP. So this is an example of how the volume time as well as the flow time waveforms will look in a patient who has a dynamic hyperinflation. As mentioned earlier, the key pathophysiology in a patient with severe asthma exacerbation is there is insufficient time for expiration. So if we first examine the flow time waveform, we see that it takes a very long time for the expiratory flow curve to actually return to zero. Subsequently, we see that the expiratory flow waveform actually fails to return to zero, suggesting that there is some component of auto-PEEP. If we look at the volume time waveform, we see that over here, during the tidal volume, it actually returns to zero at the end of expiration. But as subsequent breaths occur and dynamic hyperinflation occurs, we see that the volume does not actually return to zero, and there are subsequent increases in end-expiratory lung volume. Therefore, the goals of mechanical ventilation is actually to prevent incomplete exhalation and to prevent dynamic hyperinflation that results from breath stacking and to prevent consequences of barotrauma and hypotension. And therefore, what we want to achieve during mechanical ventilation would be that of controlled hypoventilation, minimizing airway pressure and barotrauma, and accepting a certain degree of hypercapnia to allow adequate time for expiration. So in a patient who has just been intubated for severe asthma exacerbation, the patient should be adequately sedated, and this will help to reduce oxygen consumption and carbon dioxide production from their increased work of breathing. Adequate sedation also ensures patient-ventilator synchrony and prevents the patient from breathing above the set rate, which may then worsen auto-PEEP. Usual agents employed for sedation include that of propofol and fentanyl, and midazolam can be added if required. In terms of neuromuscular blockade, rocuronium is preferred over atracurium due to the concerns of the latter having histamine release, and rocuronium is usually employed if sedation is insufficient to actually prevent patient-ventilator dyssynchrony and prevent rapid respiratory rates. And sedation when a patient is on neuromuscular blockade should be targeted for a BIS of 40 to 60, and paralysis is titrated according to the train of 4 measuring, aiming 1 to 2 out of 4 twitches, or for the infusion to be titrated to achieve ventilator synchrony. So how I set the ventilator in a patient with a severe asthma exacerbation is that I usually employ assist control volume control mode, as this allows me a more precise control of the tidal volume, and I have the peak inspiratory pressure alarms as a safety mechanism. I aim for a low tidal volume of 6 to 8 mL per kg ideal body weight and a low respiratory rate of 10 to 12 breaths per minute. This is so as to prolong expiratory time, and the effect of the respiratory rate is more pronounced in increasing expiratory time than actually altering the inspiratory-expiratory ratio. I would also increase the inspiratory flow, targeting at least 60 liters per minute to achieve an IE ratio of 1:4 to 5. So for example, if the respiratory rate is set at 20 breaths per minute, then the total cycle time is actually 60 divided by 20, which is 3 seconds. If we adopt the IE ratio of 1:5, then inspiratory time would be 0.5 seconds and expiratory time is 2.5 seconds. Conversely, if the RR is reduced to 10 breaths per minute, the total cycle time is now longer, 60 divided by 10, which is 6 seconds. And if we adopt the same IE ratio of 1:5, inspiratory time is 1 second and expiratory time is 5 seconds. So overall expiratory time is much longer if the RR is reduced. I then titrate my FiO2 to actually target at the SpO2. In terms of PEEP selection, in a patient who is deeply sedated and paralyzed, excessive PEEP is not recommended to avoid worsening dynamic hyperinflation and intrinsic PEEP. PEEP can be selected between 0 and 5 centimeters of water. The sticky airways theory is that some applied PEEP may be actually beneficial, as the applied PEEP would split small airways open and therefore overcome a dynamic airflow obstruction that occurs in exhalation and actually promote airflow exhalation from the alveoli. And how we determine whether the PEEP is beneficial or not is that we first set the PEEP at 0 and then we assess intrinsic PEEP using an expiratory pause maneuver. We then set the PEEP at 5 and assess the intrinsic PEEP again with an expiratory pause maneuver. And if we find that the intrinsic PEEP is reduced with applied PEEP, it implies that airway recruitment has actually occurred. The next mainstay of management would be that of bronchodilators. And this is actually to reduce airways resistance, which would then improve expiration. MDI puffs can be delivered into the ventilator circuit. ATS guidelines recommend 6 to 8 puffs of salbutamol or Baradual MDI into the ventilator circuit, timed with inspiration. In clinical practice, in most centres in Singapore, 10 to 20 puffs of Baradual or salbutamol are used, Q2 to 4 hourly. If NEPS is preferred, then an aerogen attachment can be attached to the ventilator circuit, and usually the total volume of fluid to be administered is 6 ml, and usually would be a component of a salbutamol and ipratropium. IV hydrocortisone should be continued. If the patient is on Symbicort or maintenance inhaler therapy, the dose may need to be increased to account for losses in the ventilator circuit. So rescue measures for intractable bronchospasm include the following. Because they are rescue measures, data is often not very strong. It's usually in the setting of case series or case reports. So one of it is a ketamine infusion, which is run at an infusion of 0.15 to 2.5 milligrams per kg per hour, and the duration of the infusion ranges from 1 hour to 5 days, and data is mixed. Another type of rescue measure that one can consider would be that of inhaled anesthetic agents, such as sevoflurane, which is administered using the Anaconda device. It's important to remember the contraindications to sevoflurane, which include that of pregnancy, severe hypotension or shock, raised intracranial pressure, and a history of malignant hyperthermia. In clinical practice, some physicians would opt for intramuscular or subcut adrenaline or even IV adrenaline, but this is highly controversial. It's found to not have a significant difference compared to beta-2 agonists in terms of treating bronchospasm, and is actually explicitly not recommended in the GINA guidelines. If the patient has severe dynamic hyperinflation, you can disconnect the patient from the ventilator and manually compress the chest to allow for passive exhalation. And if the patient has significant mucus plugging, bronchoscopy can be done for airway toileting. And for severe cases of hypercapnic respiratory failure or hypoxemic respiratory failure, then ECMO can be considered if the patient is a candidate, or ECOR, or extracorporeal removal of carbon dioxide, as a salvage measure. So this is an example of the Anaconda device, which is used to deliver inhaled sevoflurane. Most institutions have their own protocol. If you see the setup, the bottom left, the yellow circle here, is the gas elimination. In the center, you have the Anaconda syringe, and on the right, you have the Anaconda device, which is attached between the inline suction and the ventilator circuit. So usually how the settings are done is inspiratory flow is set at 40 to 60 liters per minute, automatic tube compensation is turned off, and the Anaconda device is attached. The infusion is started, targeting ET sevoflurane of 0.5 to 1.5% on the gas monitor, and further titration can be done towards ameliorating bronchospasm, dynamic hyperinflation, and hemodynamics. And because sevoflurane is a greenhouse gas, scavenging and waste gas disposable must be set up. There are several complications that can occur in patients who are having a severe asthma exacerbation. But generally, complications are rare when the plateau pressure is less than 30 and the auto-PEEP is less than 15. Scenarios that you might encounter would be that of hypotension, a high peak pressure alarm, worsening hypoxemia despite mechanical ventilation, cardiac arrest, and tension pneumothorax. So in terms of complications for hypotension, consider pneumothorax first, as this requires emergent intervention, and the next cause to consider would be that of hypovolemia and dynamic hyperinflation. So if it's hypovolemia, ensure the patient is fluid resuscitated, measure the auto-PEEP as well as the P-plat, and apply PEEP reduction measures. Consider a trial of apnea to decrease intrathoracic pressure or disconnection from the ventilator circuit. Evaluate as you would any other patient for the 4 classes of shock: hypovolemic, distributive, cardiogenic, or obstructive shock. Another complication that may arise is that of the peak pressure alarm, and it usually alarms when the peak inspiratory pressure is more than 40 centimeters of water. So when approaching a high peak pressure, think of it in terms of whether this is due to an increase in airways resistance or a decrease in lung compliance. So first I would check the ventilator circuit and looking at the endotracheal tube for any kinks. I would attempt to pass the inline suction through the ETT and suction to check patency of the tube. I would examine the patient looking for unequal breath sounds that may suggest a pneumothorax or lung collapse, auscultate for wheeze or crepitations, and I would check a plateau pressure. If the difference between the peak pressure and the plateau pressure is large, i.e. more than 5 centimeters of water, this suggests that the increase in pressure is due to an increase in airways resistance, and this may be due to ETT blockage or may be due to bronchospasm. And if it's really due to an increase in airways resistance in status asthmaticus, then what is often done is to actually increase the peak pressure alarm limit so that the patient can actually receive ventilation. However, if the difference between the peak pressure and the plateau pressure is small, this suggests a decrease in lung compliance, of which causes to consider in an asthmatic patient would be that of lung collapse due to mucus plugging, a pneumothorax, but other causes such as pneumonia, ARDS, pulmonary edema, or raised intra-abdominal pressure are also possible. If the peak pressure alarm is excessively high and the ventilator keeps alarming and you're not able to deliver a breath, you may need to actually disconnect the patient from the ventilator to allow for passive exhalation and consider manual chest compression at the same time. Intermittently, bagging can be performed to ensure a certain degree of ventilation. However, it is also important to remember the pathophysiology where in asthmatics what they have is an increase in dead space. And minute ventilation is composed of both alveolar ventilation and dead space ventilation. And because of the predominant increase in dead space, an increase in minute ventilation by bagging faster and harder may not translate to an increase in alveolar ventilation and may actually worsen dynamic hyperinflation and hypotension. In a patient with worsening hypoxemia with status asthmaticus, consider pneumothorax, lung collapse from mucus plugging, progressive bronchospasm, and other causes such as pneumonia, ARDS, endotracheal tube blockage, displacement, right main stem intubation, aspiration or raised intra-abdominal pressure. A common complication in asthmatic patients with severe autopnea would be that of pneumothorax due to barotrauma. It's important to remember that a pneumothorax may not be apparent in a patient who is mechanically ventilated and supine, and the chest radiograph findings are different from that of an ambulatory patient. One of the common signs we see in the ICU is that of a deep sulcus sign, which is illustrated in this chest x-ray over here by the red arrow, where the sulcus appears deeper than normal. Management of a pneumothorax would include that of a needle decompression in the second intercostal space if it's a tension pneumothorax. Otherwise, most patients on mechanical ventilation will require large bore chest tube insertion as the air leak is often large, and this would necessitate blunt dissection and insertion of a 24 to 28 French chest tube. A bedside ultrasound can also be employed, looking for ultrasound features such as a lung point, which is a transition point between normal lung sliding and absence of lung sliding, and this is highly specific for pneumothorax. Other signs include that of absence of lung pulse, whereby the pleural line is seen to be pulsating in tandem with the heart, as well as the stratosphere sign, which is absence of lung sliding in M mode. So in a patient with a severe asthma exacerbation who suddenly develops a cardiac arrest, consider a critical lung hyperinflation as well as tension pneumothorax as your top differentials. So in critical lung hyperinflation, what happens is there's a decrease in preload to the right ventricle, and the increase in the intrathoracic pressure is transmitted around the pericardium, causing a tamponade physiology, and this causes severe and profound hypotension leading to cardiac arrest. For tension pneumothorax, treatment would involve that of needle decompression. So if it is a status asthmaticus patient who suddenly cardiac arrest, do consider a trial of apnea or hypopnea for about 30 to 60 seconds with circuit deconnection and external chest compressions, a volume challenge, and otherwise continue ACLS as per usual. Consider also the usual 5 H's and 5 T's. Okay, so now the patient with asthma is now better and you're actually weaning and trying to liberate them from mechanical ventilation. How do you actually select the PEEP? So in selecting PEEP in a patient with asthma exacerbation, there's a waterfall theory, which basically states that as long as the applied PEEP or the extrinsic PEEP is less than the intrinsic PEEP, the extrinsic PEEP will not worsen the intrinsic PEEP. And this is akin to a waterfall over a dam, as illustrated over here in this diagram. So if your auto PEEP is 10 and your external PEEP is 0, you will not worsen the auto PEEP. If your auto PEEP is 10 and your external PEEP is 10, you will not worsen the auto PEEP. However, if your external PEEP is more than the auto PEEP, for example, if it's 12, the net PEEP will actually be higher than 12. And therefore, in weaning a patient with status asthmaticus, we'll actually set the extrinsic PEEP to 70 to 80% of that of the intrinsic PEEP. And why we actually choose to apply PEEP in patients with severe asthma exacerbations who are being weaned is that it actually reduces the work of breathing. It prevents ineffective triggering as it reduces the pressure gradient needed to trigger a breath, and it only applies to spontaneously breathing patients. So if we look at the diagram on the right side of the slide, this is on the left panel, this is a patient who has an external PEEP set at 6 and a trigger threshold that is set at 2 below the level, i.e. 4, and therefore they only need to generate a pressure gradient of 2 to actually trigger a breath. In contrast, on the right hand side, we have a patient with a set PEEP of 0 and a trigger threshold of 2 centimeters below that level, which is -2, and the patient has an intrinsic PEEP of 6. What happens is that the patient actually needs to generate a pressure difference of 8 to trigger the ventilator, and therefore has to generate a much higher pressure difference and they have a much higher work of breathing. In summary, for today's session of Quick Care Bites, we discussed how to mechanically ventilate a patient with a severe asthma exacerbation, some rescue maneuvers that can be considered, common complications that may be encountered, and how to wean these patients from mechanical ventilation subsequently. Thank you.